Hello, welcome to this webinar. It is organized by Science Communication Hub Nigeria in collaboration with Train in Africa, Africa Science Literacy Network, and Africa Archive. The emergence of the new coronavirus responsible for the COVID-19 pandemic has caused an unprecedented health challenges and disruption in human activities in the world. The world has not witnessed in many decades. As of today, the 6th of June 2020, about 6.8 million people have been infected with the virus, and close to about 400,000 people have died from the virus globally. The NCDC, that's Nigeria Center for Disease Control, confirmed about more than 11,800 cases in Nigeria and 333 deaths. However, about 3,700 of those cases have recovered. The virus has been confirmed in all but one state in Nigeria, and a lot of measures have been put in place to curtail its spread. To discuss the successes, challenges, and ways forward as it relates to the COVID-19 response in Nigeria, we have a panel of experts, seasoned experts that are in the forefront of fighting the pandemic in Nigeria. I am Dr. Jamili Nicole. I will be moderating this session. There will be an opportunity for your questions to be answered by the panelists. If you have any questions, kindly post it on the comment section of the medium you're watching us. That is either YouTube or Facebook. Before we start, let me tell you something about our panelists. The first is Dr. Chinwe Lucia Ochu. She is a medical doctor with over 24 years experience as a clinician. She has an MBBS degree from Ndadilnasiya University and a master's in public health from University of Liverpool. She currently works with Nigerian Center for Disease Control as the Acting Director of Prevention, Programs and Knowledge Management and the Head of Research. She represents NCDC at the National Lassa Fever Research Consortium, National Health Research Committee, and National Health Research Technical Working Group, and she is the coordinator of the Nigerian COVID-19 Research Consortium, NCRC. Dr. Ochu was part of the Health Development, Implementation, and Funding Partners Deliberation on tackling bottlenecks that impede access to healthcare innovation. She was also a speaker at the 2019 World Health Summit, and she represents Nigeria at the United Effort for Innovation, Access and Delivery, a UNDP Japanese government-funded partnership. Our second panelist is Dr. Iman Odaibando. He's a public health physician and an epidemiologist with masters in public health from Bello University Zaria and the Nigerian Field Epidemiology Training Program. He has several years of technical and managerial experience in delivering public health interventions across the country, especially in Kano State, where he served as the program manager of the State Malaria Elimination Program and the State Saving 1 Million Life for Results Program. He was also the State Epidemiologist and Incident Manager of the State Polio Eradication Emergency Operations Center. He is currently the Director of Public Health and Disease Control in the Kano State Ministry of Health, where he oversees several public health programs like HIV and AIDS, tuberculosis, malaria, non-communicable disease, nutrition, reproductive, maternal, neonatal and child health programs, family planning, etc. He has participated in numerous disease outbreak response, and he is presently the Secretary of the Kano State Task Force Against COVID-19. The last but not the least panelist is Dr. Ndadilnasiya Endie Waziri. She is also a graduate of the Nigerian Field Epidemiology and Laboratory Training Program, and she is the national coordinator of the National Stop Transmission of Polio Program, NSTOP, at the Africa Field Epidemiology Network, AFENET office in Nigeria. NSTOP, funded by the US government, plays a major role in polio eradication initiative and improving routine immunization services in Nigeria. Dr. Waziri also teaches, mentors, and supervises current residents of MFLT program, which is geared toward building in-country healthcare capacity and strengthening health system. During the Ebola virus disease outbreak in Nigeria, Dr. Waziri led the contact tracing unit of the outbreak response, which was the backbone of Nigerian success to controlling the outbreak within a short period. Her strong leadership and effective operations of the contact tracing led to the reduction of tertiary cases to the virus minimum. AFENET has been at the forefront of COVID-19 response in Nigeria, supporting NCDC and the government of Nigeria to bring an end to this pandemic. So, having introduced our guests, we'll invite our panelists to tell us what are the successes they have recorded so far in the fight against COVID-19 pandemic in Nigeria. So let's start with the organization that is responsible for coordination of COVID-19 response or any outbreak response in Nigeria, that's NCDC. So let's start with Dr. Ochu from NCDC. Dr. Ochu, can you please unmute yourself?
Sorry, I forgot I was muted. So thank you, Jamilu. I said to talk about the successes we have recorded in the fight against COVID-19 in Nigeria, I think it's good we have a bit of a background because for you to measure your success, you should know your baseline, where you were before COVID-19 met us and where we are now. So the baseline was that we had a health system that had suffered several years of neglect and had issues, lots of issues with infrastructure and systemic issues that had to deal with healthcare worker, industrial actions, and so many things that made our healthcare system and our public health system to be weak, so to say. And we cannot compare ourselves with other countries without also comparing our baseline with the baseline of those countries. So Nigeria, for you to say Nigeria has not done as well as Ghana in the control of this outbreak, compare the baseline of Nigeria health system with the baseline of the Ghana health system. Having said that, Nigeria Center for Disease Control was established in 2011 as the Nigeria's public health institute mandated to protect the health of Nigerians from infectious disease of public health importance. So, and the Ebola outbreak of 2014 helped to test that system, and we became strengthened. Things in place, structures in place that have been helping us to fight against other infectious diseases like Lassa fever, cholera, and the rest. We operate what we call the incident management system.
Okay, so sorry to interrupt you, Dr. Ochu. We seem to have some technical challenges. Can you maybe start from the beginning, please? Sorry.
Okay, you couldn't hear me. Can you hear me?
No, we had some technical problem. Yes, we can hear you.
Okay, so let me just summarize it. I said I needed to give us the baseline. Where were we as a country in our health system before COVID-19 came? That is the only way we can measure our success currently.
Hello, Dr. Imam, can you hear me? Okay, please, we seem to have some problem with Dr. Ochu. Maybe can you just start before she sort our internet issue?
Okay, Dr. Jamilu, thank you very much for having me. This is a very interactive and nice opportunity. Dr. Chinwe has already started giving a kind of background. We all know where Kano is as the nerve center, the commercial nerve center of the nation. It's the most populous state in the nation, and with the cosmopolitan nature, of the state. So since the confirmation of the first case in Nigeria through Lagos, the State Ministry of Health, under the leadership of the Honorable Commissioner of Health, swung into action. And we quickly convened the emergency preparedness and response meeting with all the stakeholders. And at the same time, we quickly developed an incident action plan as guided by the National Center for Disease Control. That led to the activation of our COVID-19 EOC, and we set up a kind of a call center, 24 hours emergency call center. And during that time, the executive governor of Kano State inaugurated about 45 multi-sectoral, task force committee members, which is to be headed by no other person than the Deputy Governor himself, and the prominent infectious disease professor to be the co-chair. And sadly, on the 11th of April, we recorded our first index case. And the state, as the moment has the highest incidence rate and probably the highest prevalence rate based on some of the statistical modeling. And as of today, if you are following some of the publications, you will see that so far Kano has confirmed more than 980 cases with about 575 active cases. So far, we've discharged about 359 and we recorded about 46 deaths. So what are the successes? Actually, we all know COVID-19 is real. And by virtue of what is going on in the state, a lot of things has been achieved. Right from the issue of communication, ensuring that people are even aware. Where can they get tested, and will interest you to know that before the that index case, Kano did not have a single testing capacity anymore. In the whole of northern Nigeria, we cannot boast of a single identified testing. So when the index case was identified, actually, the state had neither a functional or any public health laboratory with molecular testing capacity. But all samples had to be sent to the National Reference Laboratory, Abuja, until the activation of the NCDC molecular laboratory at the AKTH. So at the moment, as part of the successes, 3 facilities that are available in the state. We have a combined daily testing capacity of about 700, and we have the mobile facility from also Endie Foundation, which has potential about 600 more tests per day current testing capacity. We were able to train about more than close to 400 personnel across all the 44 LGAs. And we will also have mobile sample collection booths, which will supplement operations. There are about 9 sample collection sites, again, none. I think you can see a great success. And at the same time, we are embarking likely on the community mass testing within the metro soon. So these are some of the things I know during the course of our discussion. Maybe I will highlight it. Thank you.
Okay, thank you very much, Dr. Imam. Maybe let's go back to Dr. Ochu from NCDC.
Okay.
Maybe if we can mute our mics.
Okay, can you hear me?
Yes, we can hear you. Please go ahead.
Okay. So, like I said, Nigeria Center for Disease Control has, as the nation's public health institute, has been responding to other infectious disease outbreaks. In fact, this year, 2020, we recorded the largest outbreak of Lassa fever so far, and we were dealing with that before COVID-19 came. So I think this helps to prepare us. We already had an activated emergency operations center responding to Lassa fever. So we had to use the same structure, the same system for COVID-19. Remember, we had already a surveillance system at the point of entry with a temperature scanner that was already in place in some of our airports, scanning people as they are coming in response to the outbreak of Ebola in DRC. So it was easy for us to use this in surveillance for COVID-19. Way before other countries started doing POE surveillance, Nigeria had started surveillance in collaboration with NCDC, in collaboration with Port Health Services. We had started surveillance at the points of entry. So when the initial case was announced in China, even before we recorded the first case, a committee was set up by the federal government, an interministerial committee, that to kind of coordinate what was happening and to coordinate preparedness activity. as well as another multi-sectoral preparedness group that was set up at NCDC, led by NCDC, that helped to develop guidelines, finalize our pandemic influenza preparedness plan, set up various pillars of response. So we're already doing this before the first case showed up on 27 February 2020. So when this happened, remember, we had just 5 testing laboratories, molecular laboratories that could test for COVID-19 at the outset. But currently we have 29 molecular testing laboratories with 3 almost ready to go. So very soon we'll have 31 molecular testing laboratories in the country using the PCR technique to test for COVID-19. And our target is to have at least one of such molecular testing labs in every state of the country. When the first case came, it was only one treatment center that was ready to admit a case, and that was the IDH in Yaba, Infectious Disease Hospital. And that was where the first case was managed. But currently we have over 100 isolation and treatment centers across the country with varied capacities. So, and we are moving, the state governments, they are setting up more isolation centers, more treatment centers, equipping them, getting them ready to respond to the outbreak. We also have a very well-coordinated emergency operations center that is multi-sectoral. So with the support of our partners, we have various pillars of response that have been working effectively. We have the IPC pillar, we have the surveillance pillar, we have the risk communication pillar, the research pillar, the logistics pillar, and other pillars. In risk communication, which is one of the strong pillars that we are using for this response, because this is an infectious disease outbreak that depends a lot on how people interact with each other. So a lot depends on our being able to communicate preventive measures to people. So we've done a lot of massive sensitization of people using various media, using various channels, the social media, we go on television, we go on radio, and then of course we have also developed information, education, and communication materials that we have translated in over 12 indigenous languages. We have also trained state health educators to be able to step down the training to those at the primary, at the local government level, so that they will be able to reach out to the grassroots. We've also engaged what we call community volunteers that are able to mix up with people at the grassroots and communicate effectively to them how to protect themselves from this outbreak. We make use also of community influencers and sensitizers like the chiefs, the traditional leaders, the religious leaders, and all those people that the community is able to trust with information. So we engage them, we train them, and we make use of them. For infection prevention and control, we've also trained a lot of healthcare workers across the country. So a lot of work is being done. Now, maybe let me just stop here. And then if I have another opportunity, I can then explain our testing strategy and how far we have gone.
All right. Thank you very much, Dr. Ochu, for the impressive outline you gave us for the work NCDC has been doing since the onset of this outbreak. So last but not the least speaker, Dr. Waziri, can you maybe tell us what your organization, the efforts of your organization has been doing for the fight against COVID-19 in Nigeria?
Thank you. Thank you very much, Dr. Jamilu, and thanks to this great platform for having me here this morning. So I work with the African Field Epidemiology Network, leading the immunization and primary health care program in AFENET. AFENET is more or less integrated into the Nigeria Center for Disease Control, especially with reference to the COVID-19 pandemic response. With funding from the US CDC, we have worked as an integral part of the response. Even before the outbreak occurred in Nigeria, as Dr. Chinwe said, a lot of structures were already in place. We had supported the Nigeria Center for Disease Control and the African Center for Disease Control to conduct various capacity building activities in country for healthcare workers, for frontline responders. And since the outbreak in Nigeria, we have also supported the government in building capacity in the various aspects of the response. We've also supported in the coordination, both at the national and at the state level. We've supported in deployment. As I speak, we've deployed over 250 rapid response team that are either residents, graduate, or staff of the African Field Epidemiology Network to all the states in Nigeria except two, as we're all aware. They've supported various aspects of the response in this state. Some of the rapid response teams are actually either led by FELTIP graduate, the FELTIP residents, or even AFENET staff. We've also supported in the epidemiology and the surveillance pillar strongly, because that is a very, very strong strength of AFENET. So we're very, very, very strong in that at all levels. When just before the outbreak, we started the points of entry screening of passengers that are returning into the country, and this was done by the current residents of the NFLT, but of course supervised by the staff of the Nigeria Center for Disease Control and the Federal Ministry of Health. And then as the outbreak progressed over time, we've tried to even help to prioritize where response should be targeted, specific needs of states, to ensure that as we deploy teams, the needs of the states are met. For instance, when there was an increasing death rate in Kano, we had to deploy people to our staff to help with the response in Kano, but also help with doing some mortality studies to see what were the causes of death or rising deaths in Kano. As I speak, we still have a large team in Kano supporting the response there. We still have a large team in Lagos. As we know, we have 3 strong epicenters for the pandemic in Nigeria, and that is Lagos, the FCT, and Kano. And our support is still very, very strong in these 3 states. We've also supported with data management. So looking at the experience we had during the Ebola outbreak in Nigeria, and actually the Ebola outbreak response gave birth to the SOMAS, which is the Surveillance Outbreak Response Management Analysis tool that we are currently using for the outbreak. Was started post Ebola outbreak, because we deployed a real-time contact tracing, monitoring, and surveillance tool that helped us to pick contacts that became symptomatic in real time, follow up other contacts in real time, and really stop the transmission. So the tool was battered post Ebola outbreak, and right now, even we still have AFENET staff that are currently supporting the data management and the use of that tool, both at the national and in other states. We've also had some of our graduates, our staff, and residents leading coordination in their various states. The person that led the EPI and surveillance team for Lagos, Dr. Bisola Adebayo, is a graduate of FELTIP, and she had worked with us previously during the Ebola response in Nigeria, and she was recently recognized by Lagos State because of her strong commitment and drive to end the pandemic. But I think I also need to say that, and I said it in the beginning, that we've done all this with direct support with NCDC, working together, not as a standalone partner. So we're completely integrated within the response system. Thank you very much.
Okay, thank you, Dr. Waziri, and our other panelists. At least Nigerians will now know what our government and other partners are doing to end this pandemic in Nigeria. So at least they have beautifully outlined the successes. However, it's not all, I think, success stories. This mean new pandemics. I'm very sure there are some issues here and there that we may need to discuss. So we welcome your questions, and panelists will be ready to will be happy to answer all your concerns. But before then, we'll be having some questions related, especially related to some of the challenges we're having. I will be directed them to some of our panelists. So the first question I'll have is for Dr. Ochu of NCDC. Testing has been described as the cornerstone of fighting this pandemic. The Director General of the WHO advised countries to test. Our testing rate in Nigeria is just to be far below the WHO recommendations. This is after 3 months after the confirmation of the COVID-19 outbreak in Nigeria. So what effort is NCDC doing to ramp up testing in Nigeria so that we can meet up with the WHO testing rate? Dr. Ochu.
Thank you again, Jamilu. Like I said in my introductory speech, that we assess ourselves based on the baseline where we started from. So testing is actually the key strategy in controlling COVID-19 infection, because a lot depends on our ability to detect, isolate, treat, and trace the contacts of confirmed cases. So, and testing is that's the only way we can know who is infected, when we test. So in Nigeria, currently we're using the molecular PCR testing technique because that is the only reliable testing technique that we have currently. And for that, because this is a highly pathogenic infectious disease, the virus is a highly transmissible one. So you need a level of biosafety in laboratory to be able to handle that kind of virus or to test for it. So we usually recommend a biosafety level of 2 and above to be able to run tests on COVID-19. And that is not what you can achieve in a day. So like I said before, we had just 5 laboratories that we had designated to run this PCR test for COVID-19 at the outset. But we are working very closely with the states to identify facilities and to upgrade them to that level that they can run the PCR test for COVID-19. And currently we have 29 of such laboratories across various states in all the geopolitical zones of the country. Some of the other states that don't have the labs, we have a sample courier transport system that helps to transfer samples from point of collection to the nearest testing laboratory. So we are using a 3-pronged approach to ramp up testing in Nigeria. The first one is this molecular lab that I've talked about now. And the second one is the high throughput cobas machine that was used for HIV testing during the NICE survey. So we have reconfigured it to be able to use it to test for COVID-19. This is a machine that can test up to 1,500 samples in a day, and we have 2 of them, meaning we can test 3,000 samples daily. We have set a target for ourselves. You must have heard our DG say so. In 3 months' time, to be able to test 2 million. I know it's an ambitious target, but it is not impossible. Because if we're able to use this machine as well as the other PCR machines that we have across the country, we should be able to test up to at least generate 3,000 from Abuja, 2,000 from Lagos, and maybe 500 tests from other states of the country. Then we should be able to test 22,000 daily. I'm talking about testing. So the third prong of our approach, is the gene expert testing mechanism that we're using for tuberculosis. So we also want to reconfigure it to be able to have over 400 of them or such machines in the country. So if we're able to pull all this together, we should be able to test up to 22,000 daily. That will give us that 2 million, over 2 million in 3 months. But that is testing, testing, testing. For you to have testing, and to continue to test, you need to collect samples, and collect samples. So if you don't have samples, you will not test. So there's a difference between having the capacity to test and being able to collect enough samples that you will test to give you that number of tests that you want to achieve on a daily basis. And sample collection is done at the state level. So different states have different capacities they are collecting different number of samples on a daily basis. It ranges from Lagos that has collected over 22,000 since the outbreak to probably maybe Kogi that has tested just 3. So various states have different sample collection strengths. What we do at NCDC is to work with these states to build their capacity to be able to collect the samples, because it's not just collecting the sample, you must also package the sample well and be able to get the sample in good shape to the lab so that they will be able to test it. So a lot of training and capacity building happens to train all these sample collectors to be able to do it right. And we have regular calls with the states. You know, at the national level, we have the Emergency Operations Center. At the state level, NCDC has also supported the states to establish state public health emergency operations centers, and they are the ones leading the response at the state level. So we usually have calls, and we are encouraging them to collect a minimum of 100 samples per day. So we are growing, we are progressing. We are not yet where we want to be, but we are making very good progress. Concerning let me say this quickly, rapid diagnostic tests, which people are clamoring for. No, there is no validated RDT currently that can give us reliable results in Nigeria. But work is in progress to try to validate some of the ones we have in the country. So if we're able to get one that can give us a valid result, we will recommend that, and Nigeria will begin to make use of it. But until that happens, our testing strategy still remains the molecular PCR testing. Thank you.
All right. Oh, thank you, NCDC, for this very elaborate plan. I'm very sure Nigerians testing capacity will be boosted if we implemented this plan. So, but maybe another follow-up to this question that Ochu is one of concerns Nigeria also have is the turnaround time for tests. Some will complain that they wait for several days or even weeks before they have their test result. So, what are we doing to actually improve this?
Okay, thank you. That's a very good question. Turnaround time, we have the general turnaround time, which is the time between the time the sample is collected to the time it gets to the lab, is tested, and the result is released. So that is the full turnaround time we're looking at, and that is what Nigerians are usually concerned about. We also have our own turnaround time, which is the time between when the sample gets to the lab and when the lab releases the sample. So at these various stages, you have challenges that could affect the total turnaround time. What we are working on, which is the one that is within our control, is that once the sample gets to the lab should be able to test and release that the result of the test within 24 hours or at most 48 hours. And the lab has actually been doing that. But there are lots of challenges from the point of collection to the point of getting it to the lab. So, and it varies among states. So, depending on the challenges. Some people, it is the problem with getting the sample to the lab, either transportation problem or poor packaging or whatever. So, there are lots of things that delay the release of results, of the result. And then, of course, when the result is released, NCDC does not communicate the results to the person that the sample was collected from. We send the result back to the state, who then communicates with the candidate. So that is the way it is done. So a lot of things can happen within this pathway to delay the release of result. Our target is result released within 24 to 48 hours. Thank you.
All right, thank you very much for the questions. So the next question is to go to the Imam. The Imam, you know that Nigeria is one of the few countries that are keeping all confirmed COVID-19 cases in isolation or treatment centers. So what has been your experience in Kano State, given the rising number of cases and agitation by some of the cases in those isolation centers, and the cost of maintaining those isolation centers in Kano?
Well, actually, Dr. Milu, as you know, from the perspective we discussed, the poor health infrastructure and the general handling of even this epidemic, even in the best hands, uh, you can imagine, preparing for war in the middle of war. So setting the isolation centers has been tough, has been one of the greatest challenges that the state, are burdened, the challenges, that is associated, economically speaking. The state largely depends on the stipend they get, the subvention they get from the federal government. To that degree, Kano, our experience was when we had the industries, we barely have just about 70 bed capacity isolation center. Luckily, we have what it takes because of the collaboration we have with the NCDC and particularly Kano Teaching Hospital, because you need the human resource for health, not only just any doctor, but you need a specialized or doctors that had, some level of training to manage. Generally, you can recall what happened. More than 100 or so doctors become infected. Right, that order that even the health workers have, of getting the personal protective equipment to work and the necessary training. So at the moment, we have about 6 isolation centers in Kano with a total capacity of about 1,000. But if the scenario base that we are looking at in a state that has about 20 million, imagine if you can just have 1 million testing positive. It becomes, really wholesome. It becomes, in fact, close to impossible. You have to take care of their feeding. You have to take care of their medications. You have to ensure that everything, they do from the time they tested, to the time, they stayed at least, the minimum of 14 days. And we've discussed about the issue of testing time, which is a major hallmark. Test, and test. With the challenges that Chinwe said, in Kano, we experienced even worse than that. Because during the initial phase, we didn't even have the lab. So you have to take the sample, to Gadua. You have to sometimes even escort it with police. And before you go there, all the challenges of leveling, you have to ensure that the case investigation form is properly leveled. I think these are some of the real things, and the documentation. Of course, the results come to us, but sometimes rather late. So coming down to the isolation centers, we have the state-of-the-art facilities in one of the centers, whereby all the severely, affected cases are managed. We have professors and other senior infectious disease experts. And one of the challenges, Jamilo, is the issue of those anesthesiologists and those that can give interventions where needed, especially the oxygen use, and the issue of incubation. You have to have some measure, of having an ICU, when those cases are deteriorated. So this has been a big challenge. I know most of the states in northern Nigeria, the level of preparedness for this pandemic was really suboptimal. Despite using the polio legacy and the Ebola legacy, and also, some my experience with Ghana in managing Lassa fever. But this is entirely different. But the laxity we have, I would have loved, those first 2 months, when Lagos was battling with NCDC, and even the presidential task force would have prioritized, some part of northern Nigeria, where we live, in working with our governors, so that we ensure, that we are guided, in coming up with isolation centers, that can manage this. So the challenges are now, if you have more than 1,000 cases, where would you take them to? That was why, in collaboration with the national We are coming up with the home management policy, so that we have a robust criteria, especially for those that doesn't have symptoms, to ensure that we follow them up and manage them at home. If they meet the criteria of at least having a place to isolate, they have a toilet, and we ensure that we have a rapid response team and our contact tracing team at least, monitoring them, at least, every other day, so that in case their condition may deteriorate, we can just move them to the isolation center. Yes.
All right, thank you, thank you, the Imam. I think the challenges are enormous, and it's not just in Nigeria. We can see even developed countries in the US, in Europe, and even in China, they have to pass through some periods of extreme stress. They have to improvise before they were able to overcome their challenges. I'm very sure we'll also overcome our challenges. The next question will be for Dr. Waziri. Contact tracing is an age-long effective strategy for containing outbreaks. This strategy has been one of the key components of this outbreak surveillance since the onset of the first case. Considering the widespread community transmission of COVID-19 vis-a-vis our low testing rates, does this still have value in containing this outbreak?
So thank you very much, Jamilu. So first of all, I think I want to say that contact tracing is very important, especially when you are dealing with diseases that are when you are dealing with infectious diseases, but specifically those that are highly contagious. So just to briefly say for the purpose of our audience to briefly describe what contact tracing entails, it's the process of identifying, assessing and managing people that have been exposed to disease to prevent further transmission. So contacts are people without a disease, but they've been exposed to somebody that has the disease. And when when contact tracing is systematically done, it helps us to break the chain of transmission. However, when you follow up contacts, you should also be able to test them. So for COVID-19, we follow up contacts for 14 days from last point of exposure. So for instance, if you have a case today that tested positive today and is removed from his environment to maybe a treatment center, we will start counting last point of exposure for people for those exposed to him today, and they start follow up. We start counting the 14 days from tomorrow. So generally, that is what happens. However, when you have widespread community transmission and limited testing, you prioritize contact tracing. If you throw away contact tracing because there's community spread, you will lose you will lose time. You will also encourage more transmission. So yes, there's high community transmission of the disease, but still contact tracing can help in breaking that transmission. For instance, even in the community, when you identify cases, they have immediate families, they have people they interact with directly. Um, a lot of them can actually list their contacts, even though they are not able to specify where they got, who they had contact with. You can't link that particular case to any previously known case, but they will be able to tell you about their contact. So contact tracing is very important. However, you need to prioritize, you need to look at the resources that you have, because when you have high number of cases, it means you will need much resources to also accomplish contact tracing. You can imagine following up somebody for 14 days. Right now, Nigeria is at over 11,000 cases. We're about 11,500 and something cases. Though some of them, maybe about 30% have recovered or so. So we still have about 70% that are active cases. And imagine each of them having contacts that have to be followed up. So you really need to prioritize resources. However, it is an important element of breaking transmission of highly contagious diseases such as COVID-19. Is a little bit more tricky with COVID-19 because most of the cases are asymptomatic. So, for instance, in most infectious diseases, people become contagious after the onset of symptoms. But when you have cases that don't exhibit any symptoms, so you can't even say when the person was contagious or when he will have been able to infect another person. So we still cannot throw away contact tracing. Anybody that has come up or come in contact with any COVID-19 positive case should be followed up for 14 days. If they develop symptoms before the 14 days, they should get tested. If they don't develop symptoms, it all depends on the resources that are available. They could be tested to be sure that they are not also carrying the virus as asymptomatic carriers.
Okay, thank you very much, Dr. Endie. Our audience, we've been receiving your questions, and our panelists will answer some of our questions. But maybe before then, let's also have one round of question and answer session from them, and then we can respond to the audience question. So the next question is for Dr. Ochu. There have been what some people have described as epidemic of misinformation and fake news during this outbreak, ranging from conspiracy theories about the virus being engineered in the lab to fake claims of cure and vaccines, to some people even doubting the existence of disease. How is NCDC handling this and educating Nigerians so that people will not be misled?
Okay, yes, we call that infodemic, an outbreak of misinformation and false information rumors. And that is not unusual in this kind of infectious disease outbreak because this is a novel virus. Very little is known about the virus. There's a lot of uncertainty and ambiguity around the outbreak. So the tendency for people to seek information or to even try to generate their own information, either for cheap popularity or this is a problem that we have had even in the country before COVID-19 came, where people just use their phones and make videos and just to be popular. So infodemic is a very big problem that has been associated with this outbreak, and we have never had it this bad. And part of our strategy is also to control that outbreak of false information, because it can be even more dangerous than the outbreak itself. We remember what happened during the Ebola outbreak. A similar problem cost many people their lives. So what we are doing, we are prioritizing communication. We are using strategy to counter whatever false information is out there. We have a rumor management system that helps us to track rumors about the outbreak and try to address them using the various communication channels that we have. I'm sure a lot of people have been receiving messages from NCDC. We have been working collaboratively with network operators, MTN, Glo, Airtel, and the rest. They've been supporting the spread of the correct and credible information. We also developed a dedicated site to COVID-19 just to provide information to Nigerians. We call it the COVID-19.ncdc.gov.ng. It's a microsite of our major sites. So the only way to fight rumor is to provide credible and valid information. We have a lot of media outings, and what we are doing currently is part of that communication to Nigerians and getting them informed of the truth. And what we advise every Nigerian is always verify the information you have. Go to credible sources. NCDC has its own site, Federal Ministry of Health. The states have their own information communication channels. States have hotlines that can be called. And all these lines are published on our site, on this microsite that I talked about. So you could just pick. People have been complaining that when they call, they don't get answered. It's because of the volume of calls that are coming in. And that's why we advise people to prioritize their own state hotlines. But when you call the states, they are more likely to pick than NCDC that is picking calls from over 200 million Nigerians. So those things have been put in place to help. And then, of course, at the community level, I know people are bothered about the information getting to those in the rural areas. We want the states to take responsibility for that. We are also working collaboratively with NOA and NPACDA, who usually gets to the grassroots, and they support in communicating. So what we can do at NCDC is to train those people at the state level, like the state health educators. Then we expect the states to run with that, and they have been doing that. A lot of state governments, local governments, and even traditional leaders have come on board in providing, helping to spread the correct information. Youth leaders, youth groups, school groups, NGOs. In fact, this is one outbreak that even though we have had misinformation, we also have had a lot of community mobilization towards health. Everybody is involved. We launched that #Take Responsibility tag to enlighten Nigerians and make them know that for us to control this outbreak, everybody must take responsibility. So let me stop here so that I don't take more of your time.
All right, thank you very much for your elaborate response. So the next question I will direct it to Dr. Imam is a personal one. So, but I think maybe you can share your experience. Dr. Imam, I believe you had an encounter with the virus. So I don't know if you can share your experience so that maybe Nigerians will be...
Dr. Jamilu, thank you very much. Coming up, the encounter was not really good. We had a terrible experience. Alhamdulillah, I did not have a stormy course, but seeing some of your colleagues who you are working day and night fighting this dreaded disease, succumbing to this kind of disease and nearly died, is really worrisome. From the time we developed the symptoms to the time we had the test and the result, you are just like any other person. And having been at the center, at the forefront of this, and also you are also experiencing such delays because of the turnaround time, you can only imagine. While you are battling with your life, people doesn't know, and as such, you have to keep on working, you have to keep on answering your phones, up to the time, and as at that time, we are even trying to see how can we categorize the contacts, those with mild to moderate symptoms, and those with really dire need, like I described earlier, had to go, to the, isolation center. So we received the shocking news, the anxiety, the mental fatigue, and also staying at the isolation center. The experience has really, humbled somebody to know that this virus is real. And I'm calling on all those listening to us that, there is no conspiracy. All those things, it affects you. Those typical things, that we do experience, the fever, the myalgia, the feeling of, you've been nauseated. Sometimes, some of the few drugs that you take, the common ones based on the national guideline, also, they do have terrible side effects, so people should understand that it is better for you to be prevented, to prevent yourself using the known, preventive measures of social distancing, hand hygiene, frequent washing of the hands, ensuring that when you are coming, to public, you use your face mask and you dispose it the way it should be. You ensure the respiratory hygiene, with what the Chinwe has described. This disease is certainly, it is because we've seen colleagues died. We've seen people that we know lost their lives. And those even with no any comorbidity. So I just want to draw the attention, of the public, to understand that you may not know who you contact the disease from. Like Dr. Endie was saying, this is one of the disease that it's rare that even while you are asymptomatic, somebody can contract this disease from you. And this virus doesn't have legs. We are the one that do spread it through contacts, and let me also clear the notion. It's not an airborne disease. It is not transmitted by air, but rather, the droplets, and the aerosols that we do produce when we sneeze. So ensure, even with the lockdown, of course, cannot stop, but at least it can give us some leverage of time to prepare and ensure that all our public health measures are put in place. So, Dr. Milu living in isolation center and the follow-up test also. At that time, you have to test twice, for you to be discharged. So you can imagine, the first time, it comes out, maybe it's positive, you would wonder, but I'm happy that at least from some of the suggestions we made to the national and some of the personal experience of some of our key people, the national has considered, revising the protocol. So the management is now, once you tested 14 days after, you can be discharged home. And also, it was some of our experience that really pushed, for the home management. Home-based care is also something, that at least, you are within, where you are used to. The family suffered, the community suffered, the neighbors. Everybody wants to know, what is happening. Somebody has contacted, this dreaded disease. So it's like they are losing you, but we haven't lost hope. And at the same time, the integrating back to the society in the wake of stigma and preparations for coming back to work. Even some of your colleagues will just be looking at you, are you really safe? When but eventually, with, the awareness that we are creating and seeing as, looking healthy, we are integrated back, and we continued from where we stopped. But actually, it's, and the experience is really, really something that we may not even want your enemy, to pass through. Even though, personally, I hadn't have, the stormy course, but some of our colleagues really, really, were on oxygen, some were on all the medications that, including even the second and the alluvia, and what have you, and what have you. So
Okay.
I was
Okay.
really, yes,
It
it
was
was,
really not a pleasant experience.
so that is,
And I remember,
right.
actually, I remember when I was having my test, my COVID-19 test, even the sample collection is not a pleasant experience. So I
Exactly.
think people should adhere to Dr. Imam's advice based from his experience. But we thank God for sparing your life and sparing life of most of your team members. So
Alhamdulillah.
maybe next, let's go to some of our audience. We've been receiving so many wonderful questions from our audience. So let's start with, this is the first question, I think, by
Is it Khadija?
Khadija Bobo. She said, thank you, doctors. My question is, with the present status, can we predict when we'll flatten this curve or when we can say the country is risk-free? Maybe the Endie can ask. The Endie can you respond to this one?
Okay, let me give it a try. Thanks very much, Khadija, for this question. So talking about flattening the curve, I think we need to be sincere to ourselves. We're not yet there. We're not yet at the peak of the outbreak in Nigeria. Yes, we desire to flatten that curve, but until we at least reach the recommended testing rate by the African Center for Disease Control, they have recently recommended that each country should try and test at least 1% of its population. That is, Nigeria should conduct 2 million tests. Right now, we're just at about 3.6% of that 2 million. So we are way, way, way behind. I can't tell you that we'll flatten the curve tomorrow or we'll flatten the curve in the next 2 months until we are able to up our testing rates in Nigeria, at least to be able to test 1% of our population. Then we can begin to predict that this is where we'll be at this point or at any point of as the year progresses. I hope I've been able to answer you. Thank you.
All right. Thank you. Anybody has something to ask? Maybe Dr. Imam or Dr.
Yeah, I think Khadija, looking at the mathematical modeling, some of which were supported in Kano, by some of our partners, and based on what Dr. Endie said, it will really be difficult to predict, or to say precisely when you are going to flatten the curve. Especially, if you see the way we were violating all the public health non-measures, especially in the northern Nigeria, and the state like Kano. Whenever there is, my lockdown free day, see the way we interact, see the way people, troops to markets, so while we're looking between now, and sometimes in September, but like she said, we really need to up our testing. Testing 1%, of people of Kano, you're talking about 20 million people. It's not going to be, that is what, will really give us an idea, especially with asymptomatic, large number of asymptomatic that we do have, and already, the ongoing community transmission. So many people have had the disease. Some are, having it now, but we are not, getting them through the test. Thank you.
All right, thank you. The next question, I think, is directed to NCDC by Godwin. How are we monitoring the performance of community health educators and influencers? It is not just sufficient to train them and expect them to perform.
Okay, thank you very much, Godwin, for this very important question, because a lot depends. Communication is a two-way thing, and a lot depends on you getting the right message across, the person you're communicating to understanding what you're saying. So, but like I said before, for this response, we rely so much on the states because we want the states to take ownership of the health of their own people because they understand them, they understand the sociocultural diversities, they understand the terrain, they understand what makes the people tick. So what we do is to support the states in doing this. And we already have a very good relationship and a good structure that enables us to cascade training down from the national to the state and to the local government level. And part of that strategy is also a feedback mechanism that helps us to assess. We keep evaluating. As we are talking now, on a weekly basis, we run polls that help us to get that feedback from the community. Random polls, you understand? We can focus on Kano today, next time we're focusing on Lagos, we are focusing on, so we're going state by state and getting that feedback from them to know whether the information we want them to get, they are actually getting it. So that is happening. Then at the state level, remember I said the states, they have their EOCs, the Emergency Operations Center, with their various pillars, and risk communication is one of those pillars. So they also have a work they are doing, and we don't want to undermine their work. So we only support them to do it, and they have been very effective. So they do that, they make use of those people at the grassroots level. There are community influencers, like I said before, those are people listening to. Some of the polls we have done have shown that people trust these people more than they trust the government. So if we come as NCDC to tell them, because we are affiliated to the government, they are not likely to listen to us than they would listen to their imams or their pastors or their traditional leaders. So we are leveraging this trust system and making use of it to make sure that we communicate to the people. And I think it has been working so far because the polls have also been showing increasing awareness of the disease and its preventive measures. So I hope I have answered your question, Godwin. Thank you.
All right, thank you very much.
Maybe
so we have another question. All right.
Can I just add
please,
to what?
You can add, please.
Okay, to what Dr. Chinwe just said, and thanks, Dr. Chinwe. So in adding to that, I also wanted to mention that recently the National Primary Healthcare Development Agency has started training community educators, influencers, community informants, and the traditional structures that have been working at the lowest level to improve primary health care in our communities. So using that structure, post-training, there is an accountability measure tool and a tracking system for tracking outputs from what these community leaders and community influencers will be doing on a daily basis to monitor performance and to see if we're having a change in behavior and a change in communication at the lowest level. So I wanted to bring that up in addition to what Dr. Chinwe had mentioned. Thank you.
All right, thank you very much. And then there is this question. Maybe any of the panelists can answer. Does NCDC have a plan to sequence the whole genomic sequence of the SARS-CoV-2 virus for all patients that are tested positive, as long as doing this will provide full genomic information about the COVID-19 and the pattern of its transmission, particularly for Nigeria?
Okay,
maybe
NCDC. Yes, let me go ahead and answer that because it happens to fall in my purview. Yes, genomic sequencing is very, very important, and I'm glad to announce that at least we were among the first to do that in Africa. Within the first 2 weeks of the first index case, we were able to sequence the genome and trace it back to Europe. And that is also going. We have research institutes in the country that are working so hard. And one thing we're doing now is to bring together these institutes so that we can team up and use the experts to answer most of these questions. Some of them are already doing genomic sequencing, and as we speak, there's a lot of work going on vaccine production, which relies so much on the strains of the virus that are circulating. So a lot of things, a lot of research work is going on. We have a consortium that we call the Nigeria COVID-19 Research Consortium that is working to address most of these questions. And like he said, this is research. Sequencing has to do with research. And most times in research, you don't test all the population you're researching. It might not be efficient to do that. It might not even be feasible. So what we do, we take representative samples that we could generalize and say, yes, it represents most of it. And a lot depends on the sampling technique. So that is, we can't test everybody that, do genomic sequencing for everybody that tests positive. That could mean doing that for millions of people at the long run. So it is also effective. You can take a representative sample of that population of confirmed cases and do regular sequencing to know whether there have been mutations and all those. And that is one work that is ongoing presently. Thank you.
All right, thank you very much. And then there is a question from Shagun. What is the science behind the lockdown and the easing of lockdown? For we can see that these numbers are increasing. As such, we would like to know what is driving our strategy.
Okay,
maybe any of the panelists can answer.
And then I'm sure Dr. Waziri will have a lot to say on that. Well, this is an interesting question because people have this notion that the lockdown was meant to, reduce and possibly wipe off the outbreak from Nigeria. Well, yes, that is not really the essence of the lockdown. There are two major objectives of the lockdown. The first one was to slow down transmission because since this is a disease that is transmitted from person to person, so the more you limit contact, the less likely you are to transmit, so you slow down the transmission. And the essence of slowing down the transmission was to, number two, which is the second objective, buy the public health system enough time to put in place to strengthen the public health structures and the clinical management structures to absorb whatever will come once the lockdown is eased. And that was what happened. We were able to trace more cases during the lockdown. We were able to identify them, isolate them. We were able to trace more contacts, and that's why we started seeing a hike, a spike in the number of cases that were recorded. So it was good in a sense because it helped us to identify those that already had, that wouldn't have identified if people were just moving up and down. So the lockdown enabled us to trace more cases, to track them, to identify them. it also enabled us to institute more treatment and isolation centers. During that period, a lot of isolation centers were established across the states in the country. We were able to establish more testing laboratories. We were able to recruit more contact tracers and
Hello, Dr. Chinwe? It's like she's having some challenge with the internet. Maybe that Endie, if you can conclude the other part of the answer.
Okay. Thank you, Shegun, for this question. As Dr. Chinwe had started responding to this, first of all, we were dealing with a new disease that no one was particularly sure about the mode of transmission, except that it was transmitted from person to person. And for you to reduce that transmission from person to person, you have to reduce rate of contact of people with each other. And for the only way you can achieve, you can reduce contact of person to person is by restricting movement. And we all know if you say movement is restricted, you can't tell me not to move around except you put in a system that enforces me to stay at home. And that is why lockdown came about. First of all, stay off. Let us even understand the epidemiology of this disease. It is still not completely understood, but at least to an extent, we knew that it was transmitted from person to person. So if you restrict movement, if you ask people stay at home, you're going to reduce the spread of the disease. You're also going to reduce contact. So for instance, if I'm at home and I get infected, if I'm not going anywhere, my contact will be restricted. But when movement is allowed without the lockdown, people go to places. People sometimes can't even remember where they had been to in the last 48 hours. So we needed to slow down movement so that we can slow the movement of the virus. As Dr. Imam said, the virus does not move by itself. People move with the virus. So we needed to do that. We needed to also understand the disease and put in appropriate measures to help us as a nation halt the transmission of the disease. However, we needed also to balance livelihood. So, and that is where the easing of the lockdown is coming into place. Yes, we know most of Nigerians live in abject poverty. The reason why many people don't even believe the disease is mortality rate in Nigeria has been quite low. Our mortality rate has been around 2.8%. So because it's quite low, people tell you, I would rather COVID kills me than hunger kills me at home. So there's a lot of pushback from the population because people want to get their livelihood back. Measures were not really in place to reach out to everybody with something to keep them, to keep the family going, to keep hope alive at home. So there's this pushback, and that is why the ease of the lockdown. We're not saying that the disease has stopped spreading. No. Right now, the fear, we're even having more cases of the disease, but people have less fear of the disease, unlike in the beginning where we had fewer cases and then there was a lot of fear about the disease. So we just needed to slow down the transmission, and that was why we brought in the lockdown. And I tell you, if we hadn't done this, the models that had predicted cases in Nigeria, by now we'll not be talking about 11,000 cases. We'll be talking about cases in close to millions if that lockdown wasn't in place to at least halt or reduce the rate of transmission. But we have to also balance it with people continuing lives and also making ends meet by getting their livelihood.
Thank you very much, Endie. Maybe let's have this last question. It's from Mahmoud. He said, do we know if Nigeria has passed the first wave of the pandemic? What do the public and institutions need to do to avoid a second wave in Nigeria?
So, Mahmoud, like we said earlier, we have not even reached to the peak based on all the models that we do have. And like you know, we need to continue to ensure the strict social distancing and all those public health measures of the use of face masks in public, and disposing them correctly, ensure our environmental and personal hygiene, ensure that we also wash our hands regularly, because this is what may likely hamper and break the transmission. We'll continue to ensure that our public health measures, our rapid response team continue to trust, and we need to also ensure that testing, at least if we can test 1% of the population, then we can predict when the first wave has passed, when are we expecting the second wave. If you see what is happening in Iran, and some other, places around the globe, they are, likely now, having the second wave, but in Nigeria, because of all that was explained by the panelists, it will be very, very difficult, to say that we passed the first wave, or we are approaching, the second wave. Thank you.
Okay. All right. Thank you very much, Dr. Imam, and our panelists. We have a lot of very good questions, interesting questions from our audience. But however, we can continue this session indefinitely. We need to have some time. We need to stop so that we can do some other things. So maybe to wrap up this discussion, let's just have the panelists, their perspective on ways forward and what their organization is strategizing to end this outbreak in Nigeria. So maybe let's start with NCDC, way forward, and what are the current strategy to end the outbreak in Nigeria?
Okay, so the way forward, like we have all said, is still in testing for early detection of cases, preventing transmission of diseases, and then of course managing cases as we identify them to prevent deaths. And for all this, we need everybody's support. Everyone must be willing to play his or her own role. You may not be a healthcare worker at the treatment center, a frontline worker managing these cases, but you could prevent somebody's death by passing on the right information or not passing on that false information. So that could be your own part that you're playing. So this is a whole of society approach that we are adopting, and we are calling all Nigerians to please stay safe and join in this work. This is not a health sector problem. This is everybody's problem, and everybody has a role to play. So that is my word to Nigerians. Let's join our hands together. Let's stop fighting each other. Let's rather fight our common enemy, which is COVID-19. Thank you.
Thank you for this encouraging word. And then the Imam, maybe from Kano State perspective.
I think my last words, we really need to ensure the IPC skills and the knowledge, especially for our health workers, is really, really strengthened. Testing. We need to expand our testing centers and also expand our rapid response team. And one key thing, that will really help us a great bit is targeted risk communication based on the, research, so that we can address all those issues, right to the doorstep, of the people. And also, we need to also, cooperate with the health authorities as they continue to improve and strengthen the whole health system, because this has really exposed how weak, our health system is. The provision of also personal protective equipment, is paramount, especially for us, and the expansion of the existing structures. Thank you very much.
Okay, thank you, Imam. Then let me give the last word to Dr. Waziri. What advice are you what do you want to give Nigerians to stay safe as the Presidential Task Force and other state task force are relaxing some of the social distancing measures like lockdown and some of the restrictions?
Thank you very much. So in my last words, I want to encourage Nigerians to adhere to all the non-pharmaceutical interventions that have been put in place. Let's continue to observe social distancing, continue to use masks, wash your hands with soap and water as frequently as you can, or as frequently as you can reach water. If you can't reach water, you use the alcohol-based sanitizer to decontaminate your hands. Please, if you don't need to be outside, don't be outside. If you don't need to go somewhere, stay at home. Go to places where you are only needed. Do not just go out because you want to go out. And then to us, the healthcare workers, those are the front line, we will continue to do active case search. We'll continue contact tracing, and we'll continue to engage the community so that with the help of all Nigerians, we'll be able to bring an end to the transmission of this COVID-19 in Nigeria. Thank you very much.
Okay, thank you very much. A lot of questions are coming in, but unfortunately, we don't have time to answer them. But I just highlighted the comments of Shogun, who said, "Let me thank you and all frontline health workers on behalf of Nigerians for the great work we are doing." So I think the healthline workers will be happy with this message. And then finally, on behalf of the Science Communication Hub Nigeria, I wish to thank our distinguished panelists for sparing their time based on. I know that they are all having busy schedule responding to this outbreak. To be part of this conservation, and our audience for their active participation. Thank you very much, and I hope you honor our invitation when next we invite you. Thank you very much, and bye-bye.
Thank you. Bye.
Thank you.